Okay, so we're going to start with a 44-year-old female. She was referred to the hematology clinic for thrombocytosis. Her platelet count was about 900,000 per microliter. She did not have any anemia. Her hemoglobin was 13.1. She had a normal NCV, and iron studies were normal as well, for those of you that are wondering. She had no significant personal or family history. She had a mutation panel done because of the thrombocytosis, and it was positive for CALR, NFE, and ASXL1. An abdominal ultrasound showed a mildly enlarged spleen, approximately 14 centimeters. And at one point in time, she also had von Willebrand studies that were performed. And these were, although the activity was a little below a factor 8, not factor 7, my apologies, was a little bit below 30%. The rest of them were above 30. And so not consistent with an acquired von Willebrand, but very close and low. I would also argue we probably should have ordered as well blood type, just to make sure she wasn't a blood type O. But I'm going to stop here, and I'm going to let Dr. Albertard take over.
So, as you just heard, has CALR mutation and NFE2 mutation, and as well as ASXL1 mutation. There is a germline mutation, MS4A1. The MS4A1 is exactly the same as CD20. So she has mutation in CD20, and I'll show you the detail here. Well, even for her CALR mutations, it is not your typical CALR mutation. So as you can really see it here, there is actually a deletion of 8 and insertion of 10. And so she has insertions, but it is actually at the same locus or very close to the locus. Usually we see the 5 nucleotide insertions, which is typically you see in CALR mutations, but it is a different really mutation here. And the NFE2 mutation is detected, as you can really see it here, in subclone, not in the entire clones. And this is on the RNA. We see the NFE2 mutation as well as the MS4A1 mutation. We don't see it on the DNA because the panel of the DNA does not include the CD20 genes on it. We use it for the expression, but we detect the mutation on the RNA, and the mutation actually for the CD20 is termination, which means like a loss of the CD20, of one of the allele of the CD20. And here we go. And here we are looking at the expression levels. And as you can really see here, CD19s, this is the patient, and this is normal controls that just showing them side by side to this patient. There is significant increase in CD13s, as you can expect, and but for CD20, for these genes, actually we cannot tell if there is deficiency of CD20 or not. It's not really relevant, and we don't think it is relevant in this situation. Definitely there's no increase in CD34. It is still chronic disease, and there's no increase in CD117. So again, it is still chronic disease. As you all know, there are 2 types of mutation in CALR. The 52 or 51 nucleotide deletions as well, which is type 1, and type 2, which is 5 nucleotide insertions. And in this case, it is only 2 nucleotide insertion. But for all practical purposes, everybody who studied this will say it should be considered the same as type 2. And in a principle, that type 1 is associated with myelofibrosis phenotype and significantly higher risk of myelofibrotic transformation. In contrast, type 2 is more of ET, essential thrombocytopenia types, and with low risk of thrombosis despite high platelet count. So overall, type 1 do practically worse than type 1 in a principle. NFE2 mutation, actually, not everybody really tests for NFE2 mutation, but it is very important. We see it in myelodysplasia, as well as we see it in subtypes of myeloproliferative disease. And based on this paper that was published in 21, that the presence of NFE2 mutation in myeloproliferative is associated with higher incidence of transformation into acute phase. And mutation, most of the mutations, they are actually frame shift or termination type of a mutation, which we see in these patients. And again, I mean, it can be seen with various types of diseases or mutation at the same time. And definitely this patient will do worse when it is present, and it is very important to make sure that this mutation is added into all panels for myeloproliferative neoplasms.
So thank you. I just wanted to take some time and just talk about CALR and thrombosis and just reiterate some of the things that Dr. Albatar discussed. First of all, whenever we see this mutation, we are immediately relieved. Even though the thrombocytosis may be very scary, it is also associated with less thrombosis risk in general to have a CALR mutation versus a JAK2. Platelet counts may be higher, but it's also more associated with hemoglobin and leukocyte counts that are stable. And as we all know, leukocytosis can also be a risk factor that is known in MPNs to be associated with higher risk of thrombosis. And these are all things that the CALR mutation is protected from. As you can see in the right, you can also note that patients that are CALR mutated really do seem to have an improved risk of thrombosis compared even with wild-type patients, which is also very encouraging. Despite all of this, CALR hasn't really had, the presence of CALR hasn't dictated in our adapted treatment profiles, the risk-adapted treatment profiles. We don't really consider this as something that needs to be weighed in whenever we talk about how do we treat these patients. It's still very much streamlined, and it hasn't really changed that much in the last few years. We still treat low and very low risk patients, with maybe the addition of baby aspirin, monitoring of cardiovascular risk factors, and looking for acquired von Willebrand disease. We recognize that their thrombotic risk, especially if they lack the JAK2 mutation, is actually quite low. But you can notice that in the NCCN guidelines, we don't actually have CALR incorporated in how we decide treatment guidelines either. As above, intermediate risk, we are still trying, with the lack of JAK2, we are still monitoring, need for baby aspirin and cardiovascular risk factors with the addition of cytoreduction, whether that be hydroxyurea, interferon, or maybe anagrelide, being if these patients have thrombotic risk regardless of their age, greater than age 60, plus the JAK2 mutation. So I think it's one of those interesting things that I wanted to bring to attention, how now as NGS has become more readily available, as it is easier for us to obtain molecular mutations, that is something that we need to start paying closer attention to, including the NFE2 point that Dr. Albatar brought up, because I think that this is how we might then decide, do we change course for these particular patients or not, especially once they reach the age of 60? Do we change the way that we treat them and the way that we address things for them based on the mutation profiles that they want. And right now, that's not really something that we incorporate very well, even though we have 4 different risk stratifications for ET and only 2 for PV, which is always something that I find interesting.